welcome everyone to our exciting and informative speaker series event today. Thank you all for attending. We have the privilege of hosting Professor Michael Ashby from the University of Tasmania. We thank him sincerely for his time, his insights, and for joining us here today with Palliative Care Tasmania. We would like to take a moment to acknowledge the Palawa Pakana people as the original custodians of Little Tasmania. At Palliative Care Tasmania, we acknowledge the Palawa people's deep connection to family, community, and their enduring strength and compassion in caring for their sick, dying, and grieving. I would also like to pay my deepest respect to their elders past and present, and extend that respect to any Aboriginal or Torres Strait Islander people who are joining us today. Before I introduce the speaker, I just want to do some housekeeping. We will have 30 minutes at the end of Professor Michael Ashby's presentation, just for questions. So if you have any questions during the talk, you can submit those questions via the Q&A function, which can be found at the bottom of your screen. Please join me in giving Professor Michael Ashby a warm welcome.
Thank you, Luke. I'll just go to screen sharing. I hope you can all see that. First of all, thank you very much, Luke, and thank you very much for Palliative Care Tasmania for inviting me to give this talk. Although I spend a lot of time, as we all do, on Zoom and Teams these days, it's the first time I've given a talk solely through this medium. So my title today, What Next in End-of-Life Care? This is obviously a personal perspective. What I'm about to share with you is obviously a matter of personal opinion and experience, and I'll be interested to know what you make of it all. And really, it comes off the back of a conference that I was invited to attend a few weeks ago in Adelaide, which is where I started off my palliative care career in Australia in 1989, when I arrived as a young British-trained radiation oncologist. And at that time, there was no formal qualification in medicine, postgraduate in palliative medicine. And so we really had the privilege of being pioneers and learning on the job to a certain degree. They were heady and exciting days. And I reconnected with a lot of the people I'd been involved with at that time in Adelaide, which was very nice. And the title that I gave it was a bit tongue-in-cheek, saying palliative medicine or palliative care, great start, now you can help to save the health system. And that extravagant claim really comes from my last year. I've had 17 years here in Tasmania, and most of that time has been in our palliative care service, which is now headed up by my colleague and successor, Robin Thomas, and her team. And in the last 7 or 8 years of my time, I was one of the clinical directors at the Royal, originally in the subacute space with geriatrics and rehab and palliative care and community and those things, with my wonderful colleague Bruce Edwards, who was the nursing director then. Some of you may know him. And then last year, the acting CEO asked me to take on acute medicine, the medical stream, which was medicine and cancer services. And so I spent the last year as a clinical director and in leadership in that space. And that led me to a lot of reflections about what palliative care might do in the broader system. Not to say that this is a new... Sorry, sir. Sorry, I've just got to... Sorry about that, everybody. So from that perspective of working with colleagues at the front door of the hospital, particularly in general medicine, it struck me that despite the fact that we've had really good hospital-based services at the Royal Hobart and around the country for quite some time now, there's still an awful lot of work to do that I think palliative care can contribute to trying to improve access and flow and care quality in our hospitals. So my first observation would be to you that when I started off, palliative care was very much a fringe dweller in the health system. I think it's now unthinkable to have a major health provider in this country and in many others without having a palliative care service or access to at least some palliative care advice. And whilst funding and expanding services, particularly in this area, is necessary, I think we also have to accept that our funding is no more or less stable in most places than the other services we work in the health system. Yeah, everybody's feeling the pinch and the pressure. The other thing to say is that in a place like Hobart, in our capital cities, our large population centres, we've got state-of-the-art Australian services, no question about it. We've got excellent hospice and specialist palliative care units. We've got community services, and we've got well-developed hospital services in most of our major cities. And most big cancer centres have a significant palliative care presence. I mean, it varies around the country, but there would be nowhere, I think, running a big cancer service now that wouldn't have significant palliative care input. There are obviously access issues everywhere, right across the hospital system, and that's largely due to increasing demand. And I think in the case of palliative care, probably slightly also being a victim of our own success. And I don't say that with any undue false modesty. I think there's no doubt that the services have shown what they can deliver, and they're pretty well integrated in most places. And the other big challenge, of course, in a country like this is rural and remote coverage, but that's not just palliative care, that's actually, as you know, in everything. So if you look at palliative care services in Australia, in a country like this, with this population, in an OECD, developed, wealthy country, we have about 190 deaths a year. The thing about that is that at least 75% of them are actually anticipated. So 25% are approximately, this is very rough figures, are sudden deaths. But in 75% of cases, we actually have some warning. And therefore, a certain amount of preparation and care planning is required. We know from national separation data that about 58,000 patients access palliative care in various forms each year in the health system. That's a very rough estimate across the hospital system. And we've estimated that 160,000 plus actually potentially need palliative care in any given year. These are, again, very rough projection figures. And what we have seen is over the 5-year period, in 2015 onwards, a 25% increase in palliative care related hospital admissions. In Tasmania, these are old figures, actually, it might be a bit more than this now, I'm not sure, but 4,000 deaths per annum. And our specialist palliative care services, we used to estimate, saw about roughly half of those people who were dying. Now, the other backdrop with all of this is that we have, and we're seeing every day in our health system, and I don't think any of you who are online at the moment would have escaped your attention, that getting to a doctor, a dentist, a podiatrist, almost any service that you want, let alone coming to an acute public hospital, it's tricky. The system is very, very busy, and waits can be unacceptably long. And health has an enormous economic impact. I mean, one of my roles is the editor of a bioethics journal. And in ethics, you hear time and again about scarce resources in health. That's rubbish. 30 to 50% of jurisdictional GDP is a massive amount of money. And we know here and elsewhere that our hospital budgets over the last few years have all blown out without exception around the country for a whole raft of reasons. Not the least of which is that we're very reliant on locum and agency staff to keep the services running. The other thing too is that health has an environmental impact. You know, if you ask what percentage of emissions are health related, it's not insignificant. And my colleague David Currow, who's now a Deputy Vice Chancellor at Wollongong, gave a very good keynote at Palliative Care Australia recently, pointing out the enormous ramifications of care in the community for the economics of our everyday life. And if you ask, in your family and circle, how many people have you got who could suddenly take a day or a week or a month off to care for a sick elderly relative or even a sick child? It's tricky. We're all running very close to the wire with our time and resources. And obviously the big narrative, and I mean, I don't want to labor this point because we make it all the time. We are all living on average longer than ever before in human history. And I think these are World Bank figures that show in Australia, the average life expectancy is now just over 83 years. It's a bit more for women than for men. But interestingly, if you look here, the United States with 350 million people and all levels of affluence and poverty have actually got a slightly lower expectation, which is interesting. And what Joanne Lynn in the States at the RAND Corporation pointed out to us about 20 years ago, and she actually came to Australia after doing this work, that said, basically, in the old days, we got sick and we died, and that was kind of it. It was decisive, and it was usually due to one cause, or we identified one cause, a heart attack or a gastric bleed or something like that, was for stroke, fairly decisive. Now, on average, people are likely to spend up to 2 years before death of increasing frailty with loss of muscle mass and falls risk. And this has been a massive change in the health system because, of course, we have falls nearly every single day in a large health service. Decreasing cognition, and the biggest challenge that I've ever seen, the biggest change I've ever seen in my career after the increasing incidence of cancer has been the amount of dementia challenges that we see in all parts of the health system, but particularly in the acute hospitals now. Increasing dependence. None of us like to be dependent. We like to be independent, but there's no doubt that those last 2 years you do become increasingly dependent. And let's face it, if you live alone, you're very unlikely to die in your own home unless you can bring people in to care for you. And more symptom burden. And we see that in all kinds of studies. So the area under the curve of health need has increased dramatically. And that's what we're seeing at the front door of our system. And, I think in all of this, and I know that Palliative Care Tasmania and people working in this field around the country in public health have been trying to encourage people to take matters more into their own hands. It is important that we do exercise of individual responsibility. We remember that in a country like Australia, we are lucky to have a wraparound public health system. It, of course, has its limitations and its challenges, but we all live in a fixed, compulsory mutual. It's a zero-sum game, so if you take something out, someone else may have to wait or miss out altogether. As we get older, we all need to question what we take out of the system and be clear-headed about benefits and our realistic needs and wants. We need to ask whether our needs and wishes actually align. We need to work out and we need to challenge those around us to get realistic information about our situation and the options open to us. And the question I'd ask everybody, and it is difficult, we all I think to some degree struggle with facing our own finitude. Are we willing to contemplate our own end of life and make plans for our care? And look, there have been lots of good writing. I just take two examples. Atul Gawande, who's a distinguished Boston surgeon who wrote this wonderful book introducing death and dying as a surgeon in America via a wonderful story about his aging father and what happened to him in his dying days and how he thought the system needed to change in the US. A very good read, a very popular book. Perhaps less well known was this fantastic article by Ezekiel Emanuel. His wife is actually a palliative care physician in the States, and he is a public health doctor at the University of Pennsylvania in Pittsburgh. And he wrote this article in The Atlantic, which is a very well-respected magazine there, tongue-in-cheek, saying why I hope to die at 75. It was a provocative title. He didn't mean that, but what he actually was trying to say was, when you reach 75, you're entering the prime dying time in the US. It's the same here, 75 to 85. And he was saying, we really need to ask ourselves, would we want renal dialysis? What would be our thresholds for chemotherapy of cancer? And where would we want to be? And what are we asking of those around us? What are we asking of our healthcare attendants? So that was a very provocative article. It had a very strong response, particularly as his brother was the chief of staff to Barack Obama, and quite a few of the Republican right went off and said, "Oh, here are the Democrats trying to cut us off at the knees," and all the rest of it, which he wasn't doing at all. He was just being provocative. But it was a very good article, and it's still worth a read. And why does the system change? And why do we within it resist change? W.H. Auden, the English poet, wrote, "We would rather be ruined than changed, that we would prefer to die in dread than let our illusions die." And one of Freud's analysis patients wrote that people preferred their sufferings to their opportunities. So we knew we have a strong resistance to change and to confronting mortality, and that's perfectly understandable. That's human nature. And look, over the years, people have tried. Brendan Murphy, you'll all recall, because he was the chief medical officer of the Commonwealth during the early part of COVID. And you'll remember his briefings with Scott Morrison on the steps of Parliament House in Canberra. At the time we knew him at St Vincent's, he was chief medical officer there, and he wrote this very good article in 2008, basically saying to senior doctors, you need to take the lead on end of life and so-called futile care discussions. That's a whole, the issue of futility as a concept is a whole other discussion, but it's basically saying that when you have situations where the treatment proposed has a very low chance of working, we should actually be able to advise patients not to proceed, and that we weren't actually very good at that in the system. And one of the things I got quite interested in a few years ago, I actually went on the Leicester Tavistock conference, which is a 2-week residential with a psychodynamic emphasis and what's called a temporary learning institution, around psychodynamics of leadership, mentorship, followership, and how organizations work. And one of the reflections I came out of that with is that the idea that if you really look at it, our hospital is the repository of our collective fear of death. It's a true Pandora's box where we take all of our troubles. And absolutely, we want hospitals that save our lives if we have a heart attack or a road accident, or if our kids get sick. It's essential that we do all of that stuff really, really slickly and really, really well and get the best results for people with reversible injury and illness. But we also need to recognize that ethics and technical capacity drive medical intervention and a sense of omnipotence. And as a result of that, we all tend to have unrealistic expectations of medicine and surgery and health care. And in that, there is an intrinsic difficulty in responding to dying. And there's no doubt that our hospitals are struggling, all of them. And one of the reasons is that we're failing to pick up how close a lot of people are in the elderly population who come to our hospitals, how close they are to death. So here's one study from Geelong, where we basically looked at a cohort of patients in the Geelong hospital and looked at certain criteria that were used in a thing called the Gold Standards Framework in the UK, which was a way of identifying people for palliative care need in the community. But they actually did this in a hospital, and they found that if you had frailty, organ failure, or came from a nursing home, then about 27% of the patients who came into the hospital had at least one of these criteria. And if you did, 50% of those people were dead in 1 year, and 70% were dead within 3 years. So this is not suggesting that you don't treat people. It's not suggesting that if you come into a hospital, you immediately need palliative or terminal care. I'm not saying that. But what I am saying is I think we're failing to recognize the overall trajectory of the people we're admitting to our hospitals. This is a very nice study. I haven't got the article reference here, but I can get to if you want. I just unfortunately didn't put it in time. But this is a big study from Scotland, which is a place that has a lot of very inspiring, innovative ideas about health. I'll share some of that in a minute. So death 1 year after being admitted as an emergency to a Scottish hospital. So they said that these authors said we previously shown high 12-month mortality around Scottish hospital inpatients, indicating that for many individuals, admission to a hospital is a sentinel event marking the transition to the last year of their lives. Nearly 1 in 10 patients died during the admission. Almost 1 in 3 patients had died by a year later. And this increased to 1 in 2 if you were over 85. So these are quite stark reminders of how fragile this population is. So what I'm advocating is I think we need a far wider palliative approach to the acute care of the elderly and some of the younger chronic sick. By that I mean people in their 50s and 60s who have very big chronic disease burden, particularly things like heart failure and chronic obstructive airways disease. So the thing is, everybody who comes to an acute hospital needs care, but they don't always need hospital care. If you need it, you need it. But for instance, one of the commonest diagnostic categories for people coming to our hospitals over 80 is a urinary tract infection. And in most cases, you don't actually need to be in hospital to have a urinary tract infection treated. But the problem is the other care needs are often exceeding the care possible at home or even in the nursing home. And so people default into the hospital. Now, the thing to realize also is that there's good evidence that frailty and dementia often gets worse during a hospital admission. So if we bring you in, we have to accept that the environment, with the best will in the world, will often carry things in the wrong direction anyway. And I do think we need to have a lot more emphasis on quality of life. And when I was at the Adelaide meeting, one of our guest speakers was Eduardo Barrera. Eduardo is a very, very well-known palliative care physician and researcher who started off in Canada. He's actually Argentinian, but he started off in Canada and then moved a decade or so ago to the MD Anderson Cancer Center in Houston, which is one of the world's leading cancer centers. And in the American system, he was actually able to demonstrate that if you put more emphasis on quality of life, it actually had cost benefits for the organization in terms of better patient satisfaction and shorter stays, and lots of far better feedback if people's comfort, dignity, and quality of life were attended to in a more proactive way. The other thing we need to do a lot more of is if we're going to save our hospitals, and sometimes, to be honest, it feels like that's what we need to be doing, we need to deal with what we call the preload and the afterload. Now, that's actually a metaphor from cardiology where we talk about things that before the heart that make its pumping more difficult and things after the heart in the body that make pumping out more difficult. So we have patients coming in, patients going out, and we have real difficulty with access and flow in the hospital. For instance, one of the things we've failed to realize is that our hospitals, one of their core business areas now is actually to be an emergency sheltered accommodation broker for people coming in from home who could no longer go home and need to go to some kind of supported care, usually residential aged care. And at the Royal, when I was there, you know, our crude data that we were looking at in the medical stream is it took us about, the average was about 3 weeks if you come in, that it takes then to relocate you to a nursing home. So 3 weeks in a hospital is a very long time. That means a couple of cardiac surgery cases cancelled. You know, that's the sort of thing you get into. So we need to be able to do that stuff a whole lot better. You know, we've got fantastic people in our hospitals working their socks off. I had a fantastic team there. I really feel for them because they're under the pump. I retired from the Royal in July, leaving behind a lot of very good people I'm very fond of. And they've got big challenges, and we need to support them to make these changes so that that we can continue to offer the service to the community that everybody rightly expects. And another thing we could do from palliative care is we've had a very successful, what I call a seeding grant, a project grant, if you like, from the Commonwealth for palliative care in residential aged care facilities. So each of our regions has had access to funding to employ a doctor and a nurse to work proactively in nursing homes. They've gone round, they identify palliative care need, they help to do care planning. And from what I've heard, it's been very successful. People have on all parts of the system have recognized this is really good. So I'm hoping we can do a whole lot more of that and probably link it to our growing hospital in the home, out of hospital care programs, which under the guidance of my colleagues back at the Royal are now growing quite substantially, which is great. And the other thing too is that we have a rapidly changing workforce. We have a big reliance on agency staff. There's this thing called just-in-time educational support and academic detailing that what we should be able to do is pull in educational support when staff meet challenges. And that's not just maybe about looking after a tracheostomy or looking after a PEG tube or something technical. It might also be challenging conversations and palliative care need. And our consult service at the Royal in palliative care does a lot of this work anyway through what's nearly 1,000 referrals a year. I think people don't realize that, how big the hospital component actually is. And when they go to see people, they're also informing families about options and possibilities and supporting staff to deliver better palliative care in the hospital environment. So lots of opportunities there to change the way, rather than doing big block education and then you'd never use it for a year, is actually trying to respond to things that are happening in real time. And look, this is work, I thank Professor Matthew Jose, our Professor of Medicine here at the University of Tasmania, and his renal team. And what this shows, this is a recent study they've done. It's a fantastic piece of work. It basically says that if you're over 85 and your kidneys are failing, that's what the thing at the top is there, the eGFR. Once that goes below 15 mils a minute, it means your kidneys are really struggling. You can go on to dialysis, and we certainly do that. And you do live longer if you have dialysis. Probably, I think on average, eyeballing that's about half a year, 6 months, something like that. So you survive longer, but the number of days free of dialysis is much lower than that. It's about 1.2 years. And you have more hospital admissions and you have more emergency department attendances than if you have supportive care only, that top arrow. So you don't live as long, but you spend that time at home. Our renal team were very proactive. They all did the Nephro Talk course about communication skills to break bad news and to talk realistically to their patients about their options. And they also helped us to appoint a palliative care nurse consultant to work in their team with the kidney patients. So this is one example of how we can reorientate the system to give people better quality of life. So I'm not saying dialysis is never appropriate for the elderly, but what I am saying is you need to think twice and you need to have good conversations about the options. Now, as I said, the other big challenge in the health system is dementia, the last few weeks of life. In particular, the early management, obviously, there's a whole lot of stuff going on around the country and around the world, particularly some fantastic work from Dementia Australia and similar bodies. But when it comes to death and dying, we are not very good at managing what we call BPSD and delirium and terminal restlessness, which is often not well recognized. And what I do with patients and families when I'm consulting, and throughout my time in these executive roles, I've remained an active part-time member of the consult team at the Royal with my colleagues, is that what we'll often say is when somebody is agitated and distressed and wandering and maybe violent and abusive, We say, look, what would X want to preserve their dignity and legacy? I say, let's play a thought game. Let's do a video of the way the person is now. And let's imagine we could go back like Doctor Who to their 40th birthday and show them the film and then ask them what they would want you and us to do. And I can guarantee you that most Australians would say, for heaven's sake, make sure that I'm calm and if need be, sleepy. And maybe we do need to have a discussion with our Coronial and Royal Commission on Aging people and say, we need to have the same discussion about death causation and double effect that we have with opioids. And that's a much bigger talk for another time. But I think we really need to address this because it is really difficult at the moment to adequately sedate people with dementia in the dying phase. And to be honest with some of the people on the journey as well. Advanced directives, I think, to be honest, it's taken an awfully long time. These things have been around for probably half a century, starting off mainly in the US. We've had several iterations here in Tasmania. The uptake and efficacy of them is still tricky. Lots of work going on, lots of good work, but certainly they are a very good way to have discussions with your family, your friends, your carers, your doctor, your oncologist, your specialist, and to make sure people are clear about your wishes. Goals of care that we introduced at the Royal a decade ago, and that's now a way of communicating medical goals of care within the care teams and out into the community. This has been a real game changer, and I'm very pleased to say my colleague Barbara Hayes over at Northern Health and her colleagues have been propagating this throughout the Victorian health system as well. So we've got really good ways to record discussions and decisions about decision-making at the end of life and making sure that it's not just the resuscitation that's dealt with, but also the MET calls, readmissions to hospital and all these sorts of things are captured by this tool. And so Tas Ambulance know what level of care escalation, medical treatment escalation. And by the way, I'm very clear to make sure we differentiate between care and treatment, because sometimes people talking about withdrawing care when they mean withdrawing treatment. We never withdraw care. That's a bad use of language. And unfortunately, it's crept into the lexicon for some reason. One of the last big points I want to make before we finish up and go over to questions is I'm one of the VAD providers. I'm a consulting medical practitioner in the process. I think it's really, really important for us to engage with the VAD processes. I know people may have their individual conscious views, but it's really important that we recognize that this is an area that has very broad public support. And this is probably the most important slide, but I just encourage you to have a look at the Scottish Chief Medical Officer's Realistic Medicine annual reports. There are a lot of things that we can do in the system to improve care, to more personalised approach to care, to reduce harm and waste, to reduce unwarranted variation in practice, to manage risks appropriately, and to innovate in the system and to use shared decision making. All of these things are things that palliative care can make a very good contribution to. And whilst I think, kind of trying to change people's natural aversion to confronting their own finitude, all the sorts of things that you're doing at Palliative Care Tasmania and in the community, death cafes and what have you, all a really good thing to be doing, very important. And I think you had Alan Kelleher here as a guest recently. Alan's an old friend of mine. We've worked together in the past, and I think he's absolutely right that if you use public health for seat belts and AIDS prevention, you also should adopt public health multimodal interventions in the system to improve care of the dying. And one of the key things there, combat death-denying health policies and attitudes. And I really do think now that, for instance, with falls in the system and falls as a contributor to death, we've got some work to do with our coroners and with our safety and quality people to make sure that death isn't stigmatized and problematized too much through those very necessary scrutiny processes. So look, I'll come to an end now. And I need to stop sharing my screen, stop talking, and Luke, hand back to Luke, who will coordinate some discussion. I think it's already happened. Yeah.
Thank you, Michael. That was an incredible, informative, and very engaging presentation. So thank you again for coming in and delivering that. As Michael said, we do have a Q&A session now. I think we've got about 20 minutes or so. So if you do have any questions, please pop them into the Q&A function. We've received some throughout the presentation. So I might just start us off, Michael, and then we'll work our way through them. So we've got one here. Hi, Michael. Do you think further investment by the Commonwealth into PEPA and IPEPA and other educative programs will improve wider palliative care approach, competence, and workforce development?
I think that's a question from Molly Carlisle over in Victoria, who I remember from many years ago, we were involved in various things jointly. So hello to Molly. Look, I think PEPA's been around for a long time now, and it's been very popular and very successful. And so I absolutely think it should continue to give workers from other parts of the system a chance to be funded to come into the system. Because, you know, let's face it, if you're a GP and you take a day off, you leave your practice, that has significant economic implications. And in this day and age, of course, you've got a queue at the door to deal with as well. And for our nurses from all parts of the system and our allied health workers, again, leaving their rosters and their duties and funding them to do that makes a huge difference. So absolutely. And look, the Commonwealth project in nursing homes, I think so often these things are pumped prime by the Commonwealth, and then the states are expected to pick them up. And, you know, I have sympathy for both parties because I think it's really tricky. If you look at our health budgets at a state level, you know, a little island state like Tasmania with 500,000 people, you know, it takes some of these things on is really tricky. And all our state budgets are really struggling at the moment. So I think it would be terrific to make sure that we're able to expand this work, because the great thing about it is that it was proactive. It was actually looking at palliative care need and allowing the nursing home staff, particularly the nurses, to help residents to plan ahead and communicate that to families. Very important. So yeah, I'd like to see that continue and probably integrated with our hospital in the home. What we don't want is too much balkanization of the health system with lots of little services. The more integrated they are, the better it will be.
Brilliant. Thank you. Michael, is Tasmania ready for demand? Is ready for the demand we know is coming? What can community do to prepare? And are you a supporter of advanced care planning? And does it work at the coalface of critical delivery?
Wow, that's a big question with lots of bits to it. So am I a supporter of advanced directives of advanced care planning? Absolutely. However, have I, to be honest, been disappointed? And I don't see this to all the excellent people who've worked in it, but I think it hasn't probably had the impact I would have hoped for. It's been going a long time. And look, some years ago, the US Congress actually had like their equivalent of a select committee to look at what had happened in the 52 states of the US, where they all had states law on living wills and advanced directives. And they were the first to say, oh, good old USA, you've done the legal stuff really well, but it hasn't changed very much. So the most important thing with advanced care planning is the conversations. And it's not just the professional ones, it's the ones you have with yourself, primarily, with those close to you. And then that we've got the systems to make sure that if you want to make an advanced directive, that you're able to do so in a format that is widely accepted and is then accompanies you on your journey around the system. And as a clinician, I have seen evidence of advanced directives being quoted, and we should always be asking about whether they are in existence or not. Have I seen it being a game changer? Probably not as much as I would have hoped for, to be honest. So I think we need to keep the work up there. Absolutely.
Yeah. And is there any things in particular to make advanced care planning or advanced care directives more effective? Like, is there anything in mind or anything that you've seen at different states or even different countries implement that make advanced care directive or advanced care planning more effective?
I think it's the work around the conversations.
Yeah.
And making sure that people understand that what it's about, what it is and what it isn't, and encouraging people to do it, and to have the conversations, particularly, as I said, with themselves and their families. That's where it starts. I
At
believe
its core.
that a lot of this needs to be personal responsibility. And I think publicizing it, yes, good idea. I remember a few years ago, there was a stall at AgFest. And I think some people thought, oh, AgFest, gee, we've come here to have a good time and, to look at, competitions of animals and what have you. And now we're going to talk about death. But in fact, the tent was flooded out all day and people came in and told their stories. So I think the thing is, that there's a sense that talking about death is going to make people unhappy and sad and avoidant and all the rest of it. But my experience is if you do it in the right way, it's amazing the stories that people come out with. And I still get people, knowing what I do, I've got friends who come to me and say, I really want to meet with you, Michael, because my mum's just died and it wasn't very good. And I wonder how we could have done it differently.
Yeah. Powerful conversations.
Yeah, no, absolutely.
How do we attract more clinicians to palliative care? What have you most enjoyed about working in this area?
Personally, I think I wish I had the quote in front of me, but I think I've always been inspired by a quote from a nun in Oxford, an Anglican religious sister who started off the first children's hospice in the world. And she had this wonderful quote about being around people at the end of life and how humbling and rewarding it was to work with people at such a challenging time. And I've always, that's always been a very rich thing for me. And I think it is for all of my colleagues. You know what? We don't have difficulty in attracting doctors to palliative care. I can tell you here that my colleague Robin Thomas and Carmen Holton and the crew at the Royal and at Whittle Ward, we have a queue of people wanting to train in palliative care. I think young doctors who come into it often see this is the way they really want it to be. And it's not just palliative care, but also getting people who are going to do other things to come and do our diploma, our 6-month diploma. If we had more places, we could probably train more people, but there are limits with the training, how many people you could have training clinically at any one time. But no, I think palliative care has become quite popular, certainly in this state. We have no problem in attracting people.
Brilliant.
Nursing, I'm not a good, I shouldn't really comment on nursing workforce issues, but I think in nursing we are struggling across the board to recruit and retain nurses. There's a whole other conversation around that. One of the things, obviously working in the acute medical stream that I'll share with you from my wonderful colleagues in Gen Med and on the 10th floor of the K block at the Royal, is how nurses would often say to me, look, I really think this patient needs to go to Whittle. In a way, I wish they didn't, because I wish we could do what I know they do there here, but I know that they're set up better to do it there. And there's almost a grief, that they knew what they wanted to do, but the acute system is what it is. So I think the thing about palliative care is, in a way, there shouldn't be anything special about it, because it's really the way the whole system should be.
Yeah, I think that ties well into actually the next question that we've got, which is, in your perspective, what does the ideal palliative care model look like in Tasmania to support more people dying at home?
Do more people want to die at home? I think we've dined out on this for as long as I've been in palliative care. I remember Tanya Plebiscite when she came down here just before we got the Better Access to Palliative Care program, about, I don't know how many years ago it was, and she was saying, 99% of Australians want to die at home. Actually, and we'd fed at that line, I think, to be honest. I think it's more complicated than that. And particularly people who live alone probably can't, unless family move in with them 24/7, probably for quite, and that does happen. I'm not saying it's impossible, but I think the model we have here is good. I don't think we need to change the model, but obviously we've got a capacity issue like everywhere. You know, I think we've got about 200 people on the community program at any one time. It's a lot of people. That's a lot of stories to be hanging in the air because, you know, there are various points on the journey needing support. All of our systems could certainly do with more workforce. There's no question about that. The referrals at the Royal come thick and fast, and the turnover on Whittle and on P1 is very high and very quick and very demanding for everybody. So I don't think any longer palliative care, the subject, is a problem. I think lots of people are called to it, but I think we're just short in everything.
Yeah.
There are questions about training, and I think, you know, there's probably some more thought, and I know that there's been a lot of discussion about what we might or might not do in training for nurses, particularly, and how we badge experience. Probably some more work to do in that sense, but yeah, I think workforce is a bigger issue than just palliative care. But I don't think itself it's unattractive, and I think when people discover it, they really love working in it and want to stay in it.
Yeah, and enjoy it.
Yeah, absolutely.
Next question. Over your career, what has been the biggest change in palliative care?
Well, I think it's probably the first comment I made. When I started off, it was pioneering. I enjoyed that enormously. I was very privileged. I mean, when you think what I didn't know, it's like in 1989. Oh gosh, you know, I look back, I think, oh my heavens, how did I get away with it? But we were fringe dwellers then. There's no two ways. I mean, my appointment at the Royal Adelaide, I was the first person to have that role. I was the inaugural medical director of the Mary Potter Hospice. They joined the two together. And we started off on a journey, and you look, I think it's a bit like a chemical reaction that can go either way, you know, these reversible reactions. So I think we brought something new was brought into the system by palliative care. Well, not new, but it basically repackaged, and you know, Cicely Saunders and St. Christopher's, all that pioneering stuff, brought a model of care, if you like, into the system that was missing. And it then came into the system and it changed the system. There's no question about that. It's made some changes, but also it was changed itself. So palliative care has become more mainstreamed. And I know for some people, some of my early pioneering colleagues and some colleagues have felt that we've lost a bit in that journey. And we probably have lost some things, but the main thing is to make sure that whilst we emphasize that palliative care isn't just about death, we can't avert our gaze from death and dying. That is the core business. It is about finitude. It is about actually looking at what we all struggle with, because I think, to be honest, we all do. It's like, oh, you've come into palliative care, you must have, you know, conquered your own mortality. I mean, I think that's nonsense, personally. It's for all of us. It's a land half won. It's a very complex internal thing.
Absolutely.
But I think in terms of the model, we need to keep community nursing growing.
Yep.
We need to build up the backup you can have at home so people can stay there for as long as possible. So I know that my colleagues in the hospital, in the home, in TAS ambulance, we're all looking at ways that they can back up care at home, because it is lonely out there. There's no question about it. For general practice, you know, obviously GP backup in the community is a real challenge. And I don't say that with any criticism of primary care. I think they've got enormous challenges. But I think probably to continue to develop the sort of thing, my colleague Emma Huckabee, along with Robin and the crew back in the Tasmanian Health Service, they're working really hard to build up the safety net, if you like, that will surround people at home. It is complicated. The Australian system is complicated. Most healthcare systems are. Sometimes you need a broker to find your way around it, particularly in aged care. Yeah. But I think building up those supports, because our community palliative care team can't do all the out of hours. They can't cover it all. I mean, it's out of 8 or 9 EFT. I think it's too much.
Yeah, impossible. Yeah. Question from Nick Hobbs. Do you think VAD will become an integrated part of palliative care service provision?
Thank you, Nick. Nick has been one of our very supportive social workers in palliative care, and now with our, I think, fantastic VAD navigation team. Look, I was early on. I was behind the neutrality statement for the Australian Association of Hospice and Palliative Care in the mid-90s, and I always advocated for us to be open to VAD. And I basically have been in favour of it, but I've had to walk a careful line because so many people in my discipline and lots of people in the churches and the public were very worried about this. So, but I quite openly would say I support it, and I think that there is still a certain amount of resistance in the palliative care movement nationally and internationally. There's still some people who've got their heels very dug in and still feel it's morally wrong, and or religious, from a religious point of view or whatever, or from the profession's point of view. And I think, we have to respect each other's beliefs, of course, but I think at the end of the day, the public in this country and in most other similar countries have spoken very powerfully in favour, and they've been doing it for a very, very long time. To be honest, my takeaway for palliative care is when we roll up our sleeves and care for people, we get rave reviews, but they're not interested in our ideology. No, not at all. So I think what we're seeing is that gradually, I see it in the medical workforce, our younger doctors coming through, there's a much more engagement with VAD, much more understanding of it and acceptance of it. So I think it's just inevitable. I think history will just play out here. And as I said at the conference in Adelaide to the people who feel that we should still be resistant, I say, well, first of all, you're resisting public opinion and the law. The law has changed in all the states and all but one of the territories. But, as they said of a great political party in Britain, a political scientist said that when the winds of change came after World War I, the great British Liberal Party, quite different to the Australian one, I might add, but the three parties stood there: Labour, Liberal and Conservative. The Conservatives saw the train coming and stood back. The Labour Party saw it coming and got on it, and the Liberal Party threw itself in front of the train. Which do you want to be? And I think for palliative care, I would say, I think to walk cautiously, respectfully, with the VAD providers, and to recognise, palliative care is not the only pebble on the beach anymore when it comes to death and dying. I'm going to a conference of VAD providers and VAD policymakers in Brisbane. So I'd say to people, let's walk together and recognise that our community wants this, and also to recognise the main game in time, over time, is still going to be palliative care. If you look at the fractions of deaths, it's standing around between 0.5 and 1%. I think it will climb, and we are absolutely going to have to address the issue of dementia, because I can tell you the one thing I would want VAD for, and I know it's really difficult, I'm not sure how this will play out, but if I can't recognise friends and family, if I can't toilet myself, if I can't eat myself, not only do I not want my life extended by active medical treatment of any sort, I would also very much like not to be around for that part, to be honest. I really don't. And I don't want that for myself or those around me. So that's a conversation. It's already very, I was looking at the letters pages of The Age over there when I was in Melbourne last week. And it's very clear what people are saying.
What are your thoughts on our approach to bereavement care, and any insights you would like to share on how we can do this better?
If you've got time, can you invite me back? I'd love to talk about grief and loss, because that's been another parallel passion in my career. When I went to McCulloch House as the inaugural director there at Monash, we had a few free rooms in this lovely old homestead that was turned over for end-of-life care. And they came up one day and said, look, there's a Centre for Grief Education. They've got nowhere to go. Would you mind having them here? I said, oh, that sounds fantastic. And so they moved in with us, and Chris Hall and the guys there at what is now Grief Australia have been friends and colleagues. My colleague Mary Brooksbank has just finished up coordinating a grief project in South Australia. It's very close to my heart. I think Alan with his compassionate communities, and I know this organisation has been very involved in that. Things like you know, here in Hobart, when I came here, there was this fantastic Walking with Grief group. So they, you know, it was still going. And so you actually, rather than saying, let's have a psychotherapy session, they say, well, let's go out and have a walk together. All of those things are really good. And being able to provide one-on-one or group psychological support, it's important to have that available. And we all know that, unfortunately, with the pressures of mental health, it's very hard to find that. But having pathways into that, but also recognizing most people don't need that and they actually don't want that. But obviously a broader understanding in the community. And I do some education with the students, and I say the world is very positivistic, very achievement orientated. And somehow grief and loss, you know, life is time's arrow. You go on, everything's going swimmingly well, and then suddenly something awful happens. And then you kind of get over it and then you move on with your life. And the point I make is we're all constructed as much by our gains as our losses. And so everybody will have a loss history eventually. And it's part of life. And when people are doing it tough, have we got groups? Have we got something that will speak to them? Have we got a community that understands that, oh, it's 6 months since the death, oh, you must be getting over it, sort of thing. All of those are well meant, you know, people are trying their best. Feeling often they've got to say something, when in actual fact, the evidence is overwhelming. First of all, that grief oscillates. You have your good days and bad days, and that there's actually theoretical evidence for that. So being there on the bad day, recognizing that to want to talk about the dead person is kind of normal, but it has to be driven by the person rather than by some kind of therapeutic model. So that was the sociology that Alan probably talked about, the sociology of grief. Because doctors and analysts and psychotherapists are all have a very curative model. You know, we treat you and you get better. Grief's not like that. It's an adaptation process. So yeah, lots of work we can do there, and I know that quite a lot of it is ongoing. And also, you know, when something really bad happens, what we really want is that our communities can locate their resources and understand what's going on, rather than an army of counsellors that has arrived, you know, which is not necessarily possible or actually necessarily the most effective thing to do.
Yeah, I just took the chat, and I think everyone's calling for you to come back on and definitely do another speaker series on grief and bereavement. So we'll happily have you back on.
Yeah, I'd love to do that, because there's a lot of theoretical stuff. It's actually quite interesting, the different ways that different disciplines understand grief. So very happy if you feel like it, I'd very happy to do that. Absolutely.
We can definitely arrange that, Michael. Just given the time, I know that we're sort of coming up to 12 o'clock. So what I might suggest is, if anyone does have any questions, please email them to me and we can sort of work through them. And if there's any responses that we need to get back out to, I'll happily present them to Michael and get in touch with anyone who needs or has any questions that are unanswered. But I would just, really like to take a moment to thank you, Michael, for coming in today and presenting that really informative and engaging presentation. Just before we all depart, I would also just like to thank all our PCT members that have joined us today. If you enjoyed today's event, the best way you can support us in the continued work that PCT does is to become a member. As part of the member benefits, you will get access to the recording of today's speaker series. You can scan the QR code, or you will receive an email link after today's session on how to become a member. Thank you all again for joining us. I appreciate everyone for coming in and giving us their time, and I hope you found the session extremely valuable. To stay informed about our upcoming online and community events, you can visit our website at powercaretas.org.au, where you'll find a list of our future events, activities, and palliative care and end-of-life information and resources. I also encourage you to scan the QR code and complete our speaker series survey. It takes about 5 minutes just to give us some feedback. It really helps us improve our service and what we present to you all. If you aren't already aware, no worries, Michael. If you aren't already aware, our next speaker series is next month on the 29th of October at 3 p.m. where we'll be joined by team members from the Royal Hobart Hospital Paediatric Palliative Care team, who will be representing children's cancer care and palliative care. You can visit our website, which again is powercaretas.org.au, and register today. Thank you again, Michael. Really appreciate you coming in and giving us an hour and a little bit of your time. So thank you again. It was extremely valuable, obviously, for our team, but everyone in the community. And we hope everyone enjoyed it.